Okay, great. So this is not supposed to be an all-inclusive talk, and while I do want to talk about both hypoxemia and ARDS, really it's going to be kind of focusing on the worst of the worst, which is the ARDS. And I did want to make this kind of interactive, but didn't have time to put in the um, interactive polling questions that you could have answered with a smartphone. So we're just going to really talk about ARDS. I also invite any of the ICU or any faculty or anyone that wants to chime in. This is very much joint work, joint task force, and we've included everyone across MedStar in this. Some of the hypoxemia guidelines I'm going to show at the end are not approved across the board, but are what at the moment we're working with. But like all things in this era, there is going to be a lot of moving parts, including some of these recommendations and updates. So, you know, and this is how attentive audience members at home are from everyone online as well. Really, again, most of this is going to be about defining ARDS and specifically talking about the epidemiology of what we know in the COVID. So I think a lot of the faculty are muted. I encourage you to text me, and I will try to live stream any key points and from who they're with. And Dr. Reed, if you want to join me in my room, you know, I'm happy for you to be 6 feet away from me and yelling across my shoulder. So we're going to very quickly go through this. You know, the definition of ARDS is the old definition is whatever we kind of work on. Chip, you're unmuted. So is the newer Berlin definition. And you know, I don't want to belabor this, but as you all know, we're talking about a bilateral edematous process that leads to severe hypoxemia. This is what we're intubating multiple patients in the last 24 hours in our ICUs for. And the mortality is profound. This is an old definition that was used to kind of differentiate heart failure and ARDS for the purposes of clinical trials that probably predates most of your births, but this is the old definition. I'll show you the new one. Not to go into too much detail, but this is what it looks like. While it's a homogeneous process on chest x-ray, it actually is quite heterogeneous on CT scan with dependent areas, some pleural effusions, and this gets into some of the therapeutics, and I'll come back to that slide when we talk about proning in particular. The pathology that we think we would see if we biopsied more of these people is the diffuse alveolar damage, which, you know, is the hyaline membranes. You can see type 2 cell hyperplasia in the alveolar walls and some interstitial inflammation. But, you know, that's not really so important because we're not going to biopsy any of these people. This is the Berlin definition. It takes the same general categories, and these are the major differences in red from the prior categories to make it more of a working document, a working formulation for how we diagnose ARDS. You know, they gave a more than just an acute time frame and said within a week, typically it's bilateral infiltrates or edema. And rather than having some strict criteria for pressures, which again was for the purposes of enrolling people in trials, basically the edema cannot be predominantly heart failure, and having a wedge pressure was less important. Another big difference is that this had to be done with some applied PEEP or positive end expiratory pressure. You know, before it was a PF ratio that was low, arterial oxygen tension to the amount of FiO2 or oxygen delivered. That ratio, the lower it is, the worse the oxygenation. But this added PEEP, which makes oxygenation improved, of course, so this is a little bit more stricter. And maybe the biggest difference is that there's no longer a differential for what's acute lung injury and ARDS being that more profound hypoxemia defined as 200 and less in the past, and anything with a PF ratio less than 300 is just deemed ARDS, whereas all of that was all acute lung injury before. And rather than talk about acute lung injury and then the subgroup that had ARDS, it's mild if you have a higher PF ratio, and then when you get into the 100s, moderate, and then when you're talking about double digits, you're talking about severe ARDS. And it does appear, though weakly correlated, but subsequently supported, that as you get more severe, your mortality increases, especially in this disease, probably. I'll leave this for you all. This is right from the New England Journal. You can talk about things that injure the lung directly or indirectly, but I think in this COVID era, the way that we should think about it is COVID is the most likely primary direct injury to the lung that leads to ARDS, because at least in the last few days, that's the most common cause of ARDS that we're probably seeing, at least in the last 24 to 48 hours. The management of ARDS is really to treat the underlying cause. The important thing is here, it's not a singular disease, but it is the consequence of all of these individual diseases, and managing the underlying disease is what's best. What we're largely going to talk about today is not managing the underlying disease, but how we support patients that have the syndrome while we attempt, with what limited information we have, to treat the underlying disease. And again, most of this is just supportive care more than anything else. This is a discussion about COVID, but I'm just going to quickly go through two cases. In fact, I'm not going to really go through them. I'm just going to show you that some things that look like ARDS can be pneumonia. This is from my fellowship, someone with fungal pneumonia that had bilateral fungal pneumonia. Similarly, from another institution, not all things that look like ARDS are ARDS. This is a young woman that became febrile after starting some medications for sinus infection. And on her lavage, she has eosinophilic pneumonia. So not all things that have bilateral edema per se are going to be ARDS if it's not heart failure. And the treatment for eosinophilic pneumonia is drastically different than ARDS. Just a little bit of steroids in eosinophilic pneumonia, and everything is improved. So when we see these patients, I think we're refocused now that everything is going to be COVID, especially if they're having signs and symptomatology that's consistent. But these are the general other things that we think about that can mimic ARDS radiographically. What's shown here, these 5 things are the 5 different things that can fill the alveoli. Simple fluid, blood, pus, protein, and cells that are either cancerous or other type of inflammatory cells, such as eosinophilic pneumonia, that fill the alveoli. Again, 5 categories. And then even when you have pulmonary edema, it's not as if all pulmonary edema is heart failure or ARDS, and there's plenty of other causes of pulmonary edema. And this is just more background so we're all on the same page. And I'm going to kind of quickly go through this, and these PowerPoints I'll share with Ernest, and you can review at your leisure to review pulmonary edema. But really, we're going to kind of focus on ARDS. And Ernest, you tell me if I'm going too fast or too slow, but that's really mostly the background of all of this. This is from a JAMA update that came out now approaching 2 weeks ago about what we're seeing in the COVID era. As you all have heard, about 80% of initial cases were mild, not requiring the ICU. Of all cases, about 5% of cases end up requiring the ICU and are deemed severe. A good number of these have significant comorbidities. And then there was regional differences in different parts of even China in terms of what the mortality rate was. In this initial update published in JAMA, the median onset time to onset of symptoms was 9 to 10 days before they ended up showing up in the ICU. And in this nice review clinical update, these are the key things that we're going to kind of focus on for the best evidence or best suggestion of treatment for ARDS, which is being very conservative in fluid strategies, which does not have to wait until people get into the ICU. These patients are incredibly leaky. So avoiding excessive fluid loading as much as possible to probably be something that even happens before you get into the ICU. And I'll go into a little bit of the evidence with ARDS about that. Of course, treating the underlying cause and, thinking about we're largely treating patients for community-acquired organisms to make sure that any co-infection isn't the reason for ongoing lung injury. Early invasive ventilation, and there was a good question about why we're doing it early, and a lot of it has to do with risk mitigation, but these patients also do just clinically deteriorate very quickly. We'll talk about lung protective strategies, which is the mainstay, not of therapy for ARDS, but for supportive care for ARDS so that we can avoid adding insult to injury to the lung. And then proning, which we have no clear evidence benefits patients with COVID, but are getting a lot of reports that proning does at least help with improving oxygenation. We'll talk about the pros and cons of proning in the upcoming pandemic that we're definitely seeing. And we'll talk about ECMO, but as you know, it's not something that we offer here, and we'll talk about what conundrum associated with that. There's not much here. I just wanted to focus on other things. It's really more about this slide about additional care is mostly about making sure that we're safe and protective equipment. That second to last comment, I'm going to just take a moment talking about high flow nasal oxygen and non-invasive ventilation, and at least how we're recommending or dissuading their use at the moment at the end of this presentation. This is an interesting summary of an article that came out around the same times as the WHO recommendations for treatment of severe acute respiratory infection associated with COVID. So the WHO recommendations came out on 3/13 as well. This retrospective study describing what they saw in this one hospital, Jinyintan, which is in Wuhan, is just to give you an idea of what people were seeing. So this was published mid-month. The average age of people coming into the hospital. So we're talking about that severe group of people, probably 10 to 15% or 15 to 20% of the entire cohort. These are people that come into the ICU. They were reporting 42% developed ARDS. So again, just not to make sure that we're consistent with our numbers, the overall experience was 5% of all comers in that Murthy article are coming into the ICU and have severe ARDS. This 42% is 42% of a very sick group of people that are coming into the hospital at this one hospital. And in this retrospective look at 200 patients, they were older, they had more neutrophilia or lymphopenia, hypertension, diabetes were prevalent, and prognostic factors that seem to be associated with worse outcomes include D-dimer and LDH. An article that Nate Cobb shared with me about prognosticating very poor outcome, also kind of from the same region, also pushed out D-dimer as a potential marker of poor outcome as well. Of those people that got mechanically ventilated, so roughly around 80 patients developed ARDS, the majority of them ended up on invasive mechanical ventilation, and 2/3 of them ended up succumbing to the disease. So this is a very high mortality if you develop ARDS and if you get on the vent. And I think this is a message that has been echoed in other populations around the world. I'm not going to belabor this last point. We'll talk about it at the very end. This is a retrospective study, but it stirred up a little bit of controversy about steroids. At the moment, there is no recommendation for routine use of steroids for this disease process, but we'll discuss this, time permitting, at the end of this talk or when Dan Jameson talks on Thursday. But I want to kind of focus on, if they get on the ventilator, what is it that we're doing to try to minimize the injury that happens when they're on the ventilator. The ventilator causes all sorts of injury, gross injury in terms of pneumothorax or ventilator-associated pneumonia. But really, we're trying to minimize the things that we don't see, the microscopic injury, which is the fibrosis, the oxidative injury, and potentially how stressing the lung can lead to systemic biotrauma injury. So how it affects the kidneys, the brains, the GI tract. A lot of this has to do with the fact that when the alveoli open and close all the time during ventilation, that there's a lot of force that's transmitted across those small airways and air spaces. Most of you will have lungs that are alveoli that are always open, and they just inflate and come down, but don't fully deflate and don't close. People with ARDS will have atelectasis. All those alveolar spaces are closed because of that poor function of surfactant, and counteracting surface tension forces in the alveoli are closed. I'm explaining this so that we can have a common ground. This is to make sure that everyone's on the same page with the pathophysiology of lung injury and ARDS and how that relates to therapy. The dashed line is all of you right now, and if you think about where your lung is always open, it takes very little pressure to inflate your lung. When you have lung injury, the overall compliance of the respiratory system drops considerably, shown by the slope of the solid line with lung injury or ARDS relative to normal. And there are points early on where there's alveolar collapse, then the alveoli open up, and then you get to a point of overdistension and injury. So it's real easy to ventilate somebody that has normal lung compliance with usual tidal volumes and minimal PEEP, and avoid high pressures. But you can see that the same rough tidal volume, you're getting into very high pressures. And if you're using, depending on how much PEEP and tidal volume that you're giving during the breath, there are periods of time where the experience of the alveoli are open and closed, and there are periods of time where you have overdistension. All of that is to get to the concept of lung protective ventilation, which is avoiding the open close, avoiding the overdistension, and giving tidal volumes and PEEP such that you stay in the green. In the green means that the alveoli, for the most part, are open at the beginning and end of the breath, and they're not over-distending during the course of the breath. The way that this would happen would be to give a small tidal volume and an adequate amount of PEEP, so that at end expiration, the overall experience of the lung is to avoid atelectasis. So this is the key tenet of lung protective ventilation, graphically shown. Low tidal volumes, adequate amount of PEEP. And for this landmark article, which happened at the end of my residency, was, as I started fellowship, was the big article that showed a significant mortality improvement with an ICU intervention. Very few of those prior to this, and very few of these since this as well. This landmark ARMA study was the reduction by almost 9% absolute risk reduction in death by using lower tidal volumes compared to what we were using. And these were the tidal volumes that we were using on retrospective look in the late 90s. A significant mortality benefit, a number needed to treat that's remarkably low. and low tidal volume is the ideal preferred way of ventilating. And this is based not on people's weight, but on their ideal body weight, which is determined based on the most common formula by sex and height. Trying to get through this quickly to talk specifically about COVID, but the key tenets, therefore, based on European and American societies of critical care are summarized here in a fairly recent practice guideline that was released, which is limit your tidal volumes. That evidence is strong. We do that and also limit the pressure generated by that tidal volume to a plateau pressure less than 30. And I'll show you the evidence for proning, but proning for long periods of time, not the rotisserie 4 hours, 4 hours, or 6 hours, 6 hours, especially if you prone for 18 to 24 hours, has been associated with improvements in outcome in patients with severe ARDS, the most severe ARDS. Not reaching strong consensus, but there is a suggestion that recruitment maneuvers and higher PEEP may improve survival on the ventilator. And the recommendation by this guidelines group was to avoid the oscillator. That's high frequency oscillation ventilation. So PEEP is a big question. How much PEEP? If PEEP works, does more PEEP work? Is more PEEP even better? So this is what we're saying is lung protective ventilation, an adequate amount of PEEP. Don't focus necessarily on the number here, but an adequate amount of PEEP that we avoid the lung during its inflation and exhalation from collapsing completely and avoiding over distension. But this is the average experience of all alveoli, and the specific alveoli, there are some alveoli that will still be undergoing open-close injury in dependent parts of the lung, and in more anterior or apical parts of the lung. There are some parts of the lung that might be over-distended with these same settings. Again, the line represents the mean or median experience, and there are definitely areas of the lung that will be on either side of the spectrum, and therefore over-distension can occur, and more importantly, open-close injury can happen. So the thought is, if this amount of PEEP is adequate, what would happen if we increase the PEEP? Would more PEEP be even better by avoiding more of the lung from having open-closed injury? And so at the end of the first decade of this millennia, that we had a number of studies that looked at higher PEEP protocols that compared with that original ARMA study shown on the top with higher amounts of PEEP. And there was really, in the big American study, no significant difference in survival or getting out of the hospital or time on the ventilator measured by ventilator-free days. There also was no difference in pneumothorax rate, with that higher PEEP strategy, presumably because we were limiting the volume that we were giving much more than we were in decades past. So higher PEEP overall had no benefit, but there was a signal. And the signal was that in the most severe cases of this, and this was a substantial amount of this, in this American study, there was a signal that people with more severe ARDS did have less need for adjunctive therapy and an improved outcome. This was echoed in both Canadian and French experiences looking at the same thing. So these were two studies that came out after the American study I showed you in the same edition of JAMA that showed that overall higher PEEP strategies didn't necessarily improve outcomes. But in both of these studies, along with that original American study that was published in the New England Journal, those people that got higher PEEP, if they had more severe ARDS, had better outcomes. This is a meta-analysis that looked at these three studies, the alveoli study here, the LOVES and the EXPRESS study. Again, in terms of all outcomes, there was no difference, but in the more severe ARDS group, there was improved survival, less time on the ventilator, and less salvage therapy. So this is that summary in severe ARDS defined as a PF ratio less than 150 when they looked at it. So no good prospective data, but a consistent signal in a priori decided subgroup, which is why in the consensus guidelines that I showed you that there was a moderate or a conditional recommendation for considering a higher PEEP strategy in people with more severe ARDS. The bottom line is that one PEEP doesn't necessarily fit all people that have ARDS. There has to be some way of assessing this. We're not going to get into how to assess whether or not you're, as in case person 1, over-distended, or in person 3, open and close injury around that lower inflection point. You know, it is a little bit more difficult to apply PEEP uniformly across all people. Similarly, even for an individual person, the same amount of PEEP on one day may have very different meanings the next day as people get worse or better. So, you know, PEEP overall, an adequate amount of PEEP to avoid open-close injury. More PEEP might be better in patients that have more severe hypoxemia, but this is a dynamic assessment. And there's a lot of ways to assess what the best PEEP is for different people. But for the purposes of what we're going to do going forward, we're just going to have the tables. These are the tables that we use to determine how much PEEP people require based on how much FiO2 they're on, and to see whether or not their saturation or their arterial oxygen tension is in a targeted area. If you end up being on above that area and your saturation or your oxygenation is very good, then you can move leftward along this either of these tables. If you start to get more hypoxemic and are on the lower end, which is a saturation of 88% or an arterial tension of 55, then you would move rightward. So you would go from 50% in 8 of PEEP to 50% in 10 of PEEP. Then you would go up on your FiO2 a couple of times before you go up on your PEEP if you remained hypoxemic. And this is all based on either saturation or blood gas analysis of oxygen tension. And if, again, you're using a higher PEEP table, this is the general, this is the general tables, okay? The principle of why we use diuresis, why we're keeping people dry, this is the study that, again, from the ARDSNet group, the American study about why we would run people dry. This ARDSNet study looked at whether or not to keep people well hydrated or whether or not to have them on a Lasix-rich protocol. This is a nurse-driven protocol. We have this protocol in our ICU, and it's, as far as I know, a paper order, but it can be one. It's called the FACT protocol. While there was no difference in survival shown in the upper curves, there was an improvement in length of mechanical ventilation measured by ventilator-free days. If people were left on the drier arm, which means every 4 hours, assuming that certain governors are in place to avoid renal failure, that people got Lasix, again, driven largely by a nurse-driven protocol. even though these patients got LASIK sometimes every 4 hours, there was no difference in renal replacement. And in order to get LASIK, you had to not be on any pressors. So this is if you're out of shock and certain renal parameters weren't occurring, you would continue to get LASIKs, and people would actually be able to get off the ventilator sooner. This is incredibly important in the COVID era, as we see people rapidly deteriorate, and it and keeping their volume status as dry as possible seems to be important. The other anecdotal, largely experience, I'm unclear if there's any clear data that proning improves any outcomes. Again, the mortality rate seems to be very high in those people that end up on the ventilator with ARDS, with COVID. But we're seeing a lot of reports that people seem to do better when they are prone. So again, this is not a homogeneous diffuse process. There is a differential in terms of how much atelectasis there is and how much aerated lung there is. And you can imagine that if you were to turn a patient upside down, that now all of a sudden you're improving, at least temporarily, blood flow to dependent areas and therefore those areas that are better aerated, improving overall ventilation perfusion matching. You also get the cumbersome heart off part of the lung and help aerate those basilar dependent portions of the lung. That rationale, though, doesn't totally jive with what was seen clinically. While there was a signal in earlier studies, that Gattinoni 2001 study, that proning may be beneficial again in people with more severe lung injury, it wasn't until that 2013 Guerin Provisa study that we clearly saw that there was a benefit to doing proning. And this was in patients with PF ratios less than 150. It was done within 2 days of them being in severe ARDS, but the absolute risk reduction was immense. What's really notable about the study compared to prior studies is that the duration of the prone was very long, 18 hours minimum. So it doesn't totally explain this phenomenon of just turning the patient over and improving VQ, because very quickly the prone patient is going to end up having a very similar condition to when they were unprone, where the dependent areas become atelectatic. So earlier studies looked at proning every 4 to 6 hours and flipping back. But for whatever reason, proning on a daily basis for a period of time for at least 18 hours seemed to improve outcomes. This Provisa article is a good one to look at. It has a nice addendum with a video that goes through the prone process and how it's done at the bedside. Of course, in the video, there are 3 nurses turning a 70-kilogram female patient, and that isn't the conditions that we're usually faced with. And the additional burden of this disease is the infection control issue and also resource issue, as we all are aware, with protective equipment and how quickly we'll go through it if we're doing this on a number of patients. What's notable about this study also, the Provisa Guerin study, is that almost all the patients, the vast majority of the patients that were prone had paralytic or neuromuscular blockade on board. And so while the evidence for doing early neuromuscular blockade, which I kind of took out of this, this talk, isn't really supported anymore after one look and another look. That in a recent look that kind of showed that neuromuscular blockade wasn't necessarily beneficial in all patients with severe ARDS. The one thing to remember about if you're considering proning is that it wasn't really done in isolation. It was done in conjunction with neuromuscular blockade. You know, this is not the right way to kind of look at it. This is how I had written up the ARDS-net kind of data that we just kind of went through. I'm going to show you what the MedStar cleaner version is. I think this is a little easier to see. The red items are the ones that we very quickly went through that are evidence-based. Again, using lower tidal volumes, having a conservative fluid strategy. For the most part, the lower PEEP table is the thing that has been best studied, but consideration for a higher PEEP table if you end up having more severe ARDS. And if you have severe ARDS, shown as you get across to the right here, if you have more severe ARDS with PF ratios that are 150 or less, considering proning within the first several days of therapy. All of the other, what's shown in the blue has not necessarily been evidence-based, but are things that we do for potential salvage therapy. And that includes using inhaled therapies, paralyzing early on and later, but we're doing that to try to improve oxygenation, using alternative modes such as APRV, and even considering not using the lung at all and doing ECMO. And I'll come back to some of those considerations in a second, but I really wanted to kind of first get through our general principles of ARDS management. So we kind of built on what is lung protective ventilation and why we use low tidal volumes, targeting lower intravascular volumes, using proning early on, especially for more severe ARDS, and considering some of these other things as the severity of the hypoxemia is worse. Switching things a little bit, and I'll come back to ARDS, I wanted to kind of take a step back and just discuss our specific management of hypoxemia across the inpatient population. So this first, and again, MedStar wide, this is continuing to be worked upon, so there may be changes in what we do and how we do things. But this is so far what we as a group have promulgated as our approach to the management of hypoxemia. And I'll kind of go through why. The top parts are general things, and so I'm not going to go into PPE. Hopefully that's evident to everyone. Some of the early testing probably should also include ferritin and LDH. But getting a G6PD, I would recommend, as now that's when they're hitting the ICU. And if they're COVID positive on testing, then we will initiate therapy that this is worthwhile to check, in particular hydroxychloroquine. And then thinking about if patients are deteriorating, how we're going to intubate them early on. To avoid getting them to the point where their hypoxemia worsens when they're on the floor, I think thinking about conservative fluid management. I don't want to make any strong statements about using colloid or crystalloid. In general, the SCCM guidelines that came out on Saturday endorsed a conservative fluid approach to these patients. And if they start to get hypotense or if they start to get more hypoxic, early consideration of getting to the ICU. And the reason for early is that the most aerosolized time and risk of contamination of healthcare workers and others is, of course, when we intubate. To avoid that is the primary goal of getting people to the ICU so that intubation can be done as much as possible in a controlled environment. Steps have been taken by the code committee to make sure that proper safety can be done on the floor as well. But of course, having the right nursing ratios and experienced ICU nursing and respiratory therapy and everything that we have in the ICU is the ideal place to be intubated. On the floors, nasal cannula or a non-rebreather mask. Of course, if they're on a non-rebreather mask of any significance, they should be considered for coming to the ICU. We don't have oxy masks, but if you end up going elsewhere, you'll see these masks with perforations and holes within the mask. But of course, that allows for a significant amount of aerosolization. Avoiding non-invasive ventilation, even temporarily on the floor, is probably the right suggestion. I will say very unclearly that non-invasive ventilation has been shown to be a reasonable way of dealing with the hypoxemia in patients with COVID elsewhere. There is also support from our professional groups that non-invasive ventilation might not be that aerosolizing. That is all well and good, except when you're dealing with someone with rapidly progressive hypoxemia that, as we've all seen, is fighting that mask, fighting that confinement, and is trying to pull off the mask. And given the extreme likelihood of aerosolization, the risk to healthcare workers, using non-invasive, even temporarily on the floor, should not be done. You may see it being done in the ER. This is being done with the idea of just pre-oxygenating in a closely monitored environment with airway providers right before intubation. And that's a little bit different than treating hypoxemia on the floor for a couple of hours until they get into the ICU. So we are not recommending for any sustained period of time treating hypoxemia with non-invasive as they're getting to the ICU because of the risk of aerosolization. General guidelines that we're still working with the hospitals, but I think we're okay with these current recommendations, is that anyone that gets up to 6 liters should be coming to the ICU. Anyone with a respiratory rate that's increasing above 25 should be evaluated by the ICU. And if patients have an increasing oxygen requirement, and to put specific numbers down, we said 50% in a 12-hour period, but this is really more important that we just kind of express gestalt, clinician gestalt, that if oxygenation is worsening and nasal cannula requirements are going up over a period of time, that people should be getting evaluated for the ICU. The oxy mask, again, is something that is supposed to be designed to give oxygen in a very directed way, but unlike the non-rebreather, it is not a complete mask, it is not completely closed, and it has perforations and holes throughout it, and therefore, unlike a non-rebreather, can't avoid aerosolization. I wouldn't worry about it. We don't use oxy masks here at Georgetown. This is guidelines that are being bandied about across the MedStar hospitals. When they get to the ICU, some of the same general steps, thinking about cardiac dysfunction, being safe in terms of isolation and personal protective equipment, minimizing excessive fluid loading again, usual resuscitation, 30 ml per kilogram. But and once they're in the ICU, even before they're intubated, thinking about Lasix early and frequently, or activating that fluid conservative protocol that we have, the so-called FACT protocol. Using a non-rebreather and making sure it's tight once they're in the ICU. Same reasons, avoiding non-invasive ventilation for any period of time. While there is evidence that it is reasonable to avoid aerosolization, the problem with it is that if someone's in a room behind an ante-room or with a closed door, that as soon as they pull that off, the aerosolization risk is just so significant. And we've talked a lot about in our group how the Europeans are reporting good success with non-invasive ventilation, and I would just temper that discussion of benefit to the patient with the high rate of Italian physician and healthcare worker acquiring this illness and the impact on the workforce. So while it may be beneficial in terms of improving oxygenation, it has a huge risk in terms of spreading the disease. There's a separate protocol that has been accepted about changing all nebulized therapies on the floor to MDIs as much as possible, because nebulized therapies, when not on the vent in particular, are the other big concern for aerosolization. So that protocol is up in Starport, as far as I know. We've sent it to the hospitalists. They took the protocol that's sent to the hospital is exactly the one that is MedStar wide at the moment. Roughly for albuterol, using 4 puffs by meter dose inhaler sequentially with a spacer for any patient on the floor, 6 puffs if they're in the ICU. And I encourage you to look at that Starport recommendation about nebulized therapy and minimizing it. So this is highly debated, the use of high-flow nasal cannula. Now, of course, we're already in the ICU, and I've told you why we're concerned about non-invasive ventilation. High-flow nasal cannula has an aerosolization risk. We have deemed, based on the evidence and experience elsewhere, that high-flow nasal cannula, if we avoid flow rates above 25 liters, and if you're also using a tight-fitting non-rebreather mask, also giving oxygen at what we call a flush rate or a high oxygen rate, the two together are deemed reasonable short-term options. These are in extenuating circumstances, and in most cases, again, we should be thinking about intubating patients for both treatment of the hypoxemia and minimizing the burden on spreading this disease. More to come on high-flow nasal cannula is what I'll say, and I'm going to try to finish so that there's plenty of time for questions. But at the moment, it has been used, and it was used with probably good effect in terms of at least minimizing leak, but that patient ended up getting intubated. Finally, this is what we spent most of the early part of this hour talking about, which is what happens when they get intubated. They're getting intubated for ARDS, and as means of just review of the talk, the things that we're doing is diuresing early, consider initiating that fluid protocol of diuresis aggressively in the ICU, the so-called FAT protocol. Those basic principles of lung protective ventilation, which is true for all ARDS, and the purpose of this talk is really to also give the trainees a crash course on ARDS as you're coming into the ICU potentially in the near future, if staffing so is needed. What we talk about low tidal volume ventilation and PEEP, and why we're doing this. So it's more than just following along, and you guys get what we're doing. Proning. So just a word about proning, and I think that maybe we can spend more time on Thursday with it. It certainly benefits oxygenation. As a group, I think we all are going to talk about the burden of it, especially given the high mortality in ARDS, and the burden being the risk of losing isolation and potentially contaminating the room, and the cost to healthcare worker. At the moment, I think it can be done in select individuals. As the amount of this disease increases, we will look into whether or not there are select group of people, a so-called prone team, that can do this. ECMO across the country, I will tell you, is being suggested, but there's very little experience with COVID and ECMO. At the moment, they're just small little pockets of experience with what happens and how to do it, when to initiate it. The bottom line here is that it is very time intensive, and as bed availability across the town at the hospital center becomes low, We don't foresee this as a viable potential therapy because it'll be very hard. And of course, transporting a COVID positive patient becomes very difficult. I mentioned a little bit about systemic steroids for ARDS. For those people that have asthma and bronchospasm, for those people that are in severe shock, we should be doing what we usually do with caution. The reason for the controversy about doing higher doses of steroids is that in prior data during SARS and MERS, the signal and in vitro evidence is that steroids will lead to higher viral burden. So simultaneous to that Wuhan experience that I shared from that singular hospital, in a retrospective manner, the WHO had recommended against higher dose steroids for those patients with ARDS. But there is this kind of intriguing observation that steroids, even though they had a higher severity of illness score, benefited and potentially had a mortality impact in an observation. We don't know what to do with this. It is not something that we are uniformly recommending should happen outside of the ICU. This is only in patients with ARDS, so this is going to be an ICU decision, but I think this is something to follow along with. I'll end with the general recommendations. This is the key thing that for trainees and in your residency training that you should come across in terms of the practice of ARDS, which is limit tidal volumes, limit plateau pressures. For those people with bad ARDS, there is a role for proning, but things such as higher PEEP, recruitment maneuvers. I did not talk about APRV, but we can talk a little bit more about that in a second, maybe in the question session or on Thursday. But that, all of those are more salvage methods that haven't been very well studied. The questions that were asked, I think we've answered during the talk. These were questions that Dr. Fisher gave from residents before this talk. We're doing it early to avoid aerosolization and emergent intubations that will knock out our workforce. We know that this is a rapidly progressive process that leads to profound hypoxemia. That's why we're doing it early. We've talked in detail about high flow nasal cannula being a potential temporary method and why we're not routinely recommending non-invasive, although we know that it benefits hypoxemia in these patients, but it's balancing it against the risk of contamination. There is no prophylactic dosing of medicines out there for caregivers except proper use of PPE. And then proning and paralyzing. Proning will work. It has to be done in conjunction with paralysis. Huge questions about steroids. I do not think that we will be doing ECMO just because of limited bed resources and the amount of time and the potential contamination of transporting COVID positive patients across town. And APRV, there's some additional slides at the end of this, but I'll probably not discuss it anymore and just give a few minutes for questions. But it is something that will improve oxygenation, but has never been proven to necessarily improve outcomes in ARDS. So Ernest, any way that you want to get across questions for 5 minutes?
Well, I have my own question. Can you hear me?
Yes.
So I wanted to bring this up because you kind of briefly mentioned it. Of course, we're doing conservative fluid management. The WHO, I guess they had two versions of this because I saw it online, and they said 30 per kilo, but then they've changed this to 250 per 500 ml boluses at a time. And I think just to make us think more about how much fluid we're giving. But going to this FACT trial that you talked about, like looking at the group that's conservative versus liberal, like they're almost net even. And so would you recommend us on the floor to be trying to shoot for net even? And does that mean we're giving Lasix while they're on the floor?
The only way to really get net even is often to give Lasix. Number of ICU studies looking at fluid burden in the first few hours of acute care in the hospital and acute care in the ICU shows drastic amounts of positivity in fluid balance. So yes, the studies, that FACT study, they didn't really get to their hemodynamic goals. They didn't get people largely negative, but what they really avoided is fluid positivity. The lung is extremely leaky, and in this condition and conditions that lead to ARDS, and minimizing the hydrostatic pressures minimizes the leak. And there's no recommendation about using the FACT protocol outside the ICU, but I just inside the ICU, there's just a question about expanding it beyond just those patients on the ventilator. But I think the more important thing is exactly what you said, which is trying to avoid positivity, using Lasix as clinically as possible, and the 30 mLs per kilogram is the usual recommended, and that is fairly conservative compared to historical controls. That's the recommended initial bolus for patients with sepsis, but we should probably be even more conservative. Our recommendation was 20, my recommendation is 20 mLs per kg. That comes from nowhere else but just individual recommendation. And I think another reasonable way is that usually works out to about 1 liter of fluids for someone that's coming in acutely hypotensive. But giving 250 and 500 cc boluses at a time also makes sense.
And then we would potentially be calling you in the ICU sooner for considering pressors rather than continuing a second 20 or 30 per kilo bolus.
Yeah, there's a separate triage document that has been really vetted, and if it's not out yesterday, it should be out today on Starport. And part of the triage, and I shared it with a couple of hospitalists, and I don't know how widely disseminated it is, but I'm kind of waiting for the full recommendations to come out. But they do echo what I sent out, which is one of the criteria for coming to the ICU is if you're noticing that you're giving fluids, even if you're at 2 or 4 liters, consider getting to the ICU sooner if there's persistent need for ongoing crystalloid use. That is definitely a triage consideration for the ICU.
And what about anything considering colloid use?
There's no recommendations. The SCCM recommendations for COVID that came out on Friday basically said that there's no data for colloid or midodrine. So there's nothing to guide us with this. We deal with a group of patients that is a little bit different than probably the average ICU population. I'm talking about our liver population that is very hypoproteinemic. So I don't think that I can give you a strong opinion except my own personal opinion. I think that we should probably avoid crystalloid as much as possible, and in select patients be using albumin up front once they get on the vent. The burden of resource risk and mortality is immense, and anything that we can do to mitigate that, either early identification, early therapy, whatever it is, early testing, which now we have for whatever time we will have it, are all things that hopefully will improve avoiding getting into ARDS. Because if they're test positive, maybe we can give hydroxychloroquine earlier is the point, and that might decrease viral burden.
There's a few other questions coming in, but I think we're at the kind of time limit, so maybe we'll save them for Thursday.
Anything burning one question?
Let's see here. This one seems like it might be a little tricky, but do we know if there's a benefit for early initiation of the hydroxychloroquine azithromycin combo? And should we be thinking about it on the floor rather than ICU?
Yeah, that's a great question. I think if they're positive, the ID team and there is a therapeutic document that's coming out that Dr. Timpone along with Raj Santi and the PharmD group along with MedStar has come out with. And I think right now the recommendation is when they're COVID positive, and that's probably a prudent thing given maybe shortages and resource utilization to wait until they're COVID positive. But I think that's the time to consider it. Unfortunately, it would be nice if we had now with quicker testing, hopefully we can get people therapy sooner. Dr. Reed wants to be unmuted.
And then there's I'll unmute him while I'm doing this, but there's a couple questions which I don't know if this is going to be an easy answer, but about the cardiac involvement with COVID.
Yeah, we're seeing cardiac involvement. There's, myocarditis, there's arrhythmia. We're seeing it as oxygenation gets worse. We're seeing it as oxygenation improves. Not much prospective information that I can offer you. That's why we kind of put focus in cardiac exams here. That is a personal preference. We're trying to, but there's no way of necessarily screening for it. The only concern, of course, with using things that prolong QT like azithromycin and hydroxychloroquine is, could that make things worse? No one knows. The bottom line is that we don't have a lot of information on how and who to screen for it or what clinical features might predict cardiac dysfunction, but it's not happening, uniformly as people get worse. It's happening even when people get better.
I want to chime in. Can you all hear me about the azithromycin and chloroquine question? So, can everyone hear?
I can hear you, yes.
Okay. So the point about it is that ID is going to be consulted on every COVID positive patient in the hospital. This medicine combination is not to be given to PIUs, and it's only to be given to the COVID positive, and it's only with ID approval at this point. So we don't want, there are some limited resources. There has been death from chloroquine overdosing. This is not something that should just be written for by house officers or, hoping to get through. The important thing about this particular disease and dealing with this is that, and I sent this out to my group, everybody is looking at all the literature out there and all filtering and coming up with ideas. But we as a team, as a MedStar team, needs to be on the same page and doing it the same way across the board. And there are committees that are at the corporate level that are reviewing all of this data to come up with recommendations. So we can't have lone wolves out there practicing different from the rest of the group. So in terms of the therapy and when to start the azithromycin and chloroquine, it's done with ID on board, and it's for COVID positive only at this point. Now that may change in the future.
Yeah, and there's been plenty of concern about, initial data changing. Even in chikungunya, the initial thought was that hydroxychloroquine and chloroquine would improve outcomes. And what happened after the fact is that people had more persistent symptoms, and for months later, the fevers and muscle aches of chikungunya was worsened if you got hydroxychloroquine and chloroquine therapy. So it absolutely echo ID and best evidence with them on board as well. This is a moving target, and certainly resource utilization is a huge driving factor in how we give care.